we see that the variation in mortality in our country is not depending on the region, it's not depending on the number of beds, teaching hospital or no teaching hospital. I think that the variation exists because of a kind of invisible engine in an organization. What I hope is that we will learn to understand that invisible engine. And what I hope is that FlaQuM, or the quality management system that we are building, the UniQM for the future, that will describe the invisible engine. We will only be able to change it if we understand it first.
Welcome to Leading Quality, the podcast spotlighting the people moving healthcare forward from the front lines to the C-suite. I'm your host, Jason Meadows. Professor Kris Vanhaecht is a full professor in quality and patient safety at KU Leuven in Belgium, where his work focuses on healthcare quality management, patient safety, care process redesign, clinical pathways, person-centered care, and support for clinicians after patient safety incidents. He is also an IHI Improvement Advisor, a member of the International Academy for Quality and Safety, and chair of the board of directors of Cienzano, Belgium's National Public Health Institute. Kris has published extensively in the field with more than 13,000 Google Scholar citations, and in 2026 received the BMJ IHI Inspirational Story Award at the International Forum on Quality and Safety in Healthcare, recognizing an individual whose quality and safety journey has moved others and sparked change. In this episode, we focus on the Flanders Quality Model, or FlaQuM, which emerged after hospitals in Belgium began asking how to move beyond episodic, accreditation-driven quality work towards something more sustainable. FlaQuM was co-created with hospitals, clinicians, executives, patients, and quality leaders, and combines classic quality thinking with serious attention to leadership, culture, context, and shared learning. Kris brings an exceptional combination of academic depth, practical implementation experience, and policy perspective. We talk about why co-design matters, why context and culture can't be ignored, and why quality leaders need both universal principles and local translation. Professor Kris Vanhaecht, welcome to the show.
Thank you for having me, and thank you for the invitation, Jason.
You're very welcome. Been looking forward to this. I'm curious if we can start with a bit of a broad overview of you and your background. I will have given a fulsome introduction, but I'd love to hear in your own words kind of what pulled you into quality in healthcare as the work that you wanted to devote yourself to.
Well, it's an interesting question, and it goes way back. If people ask me where my career started, I have to tell them the story of 38 years ago. I'm 52 right now, but at the age of 14, I saw an ad in the local newspaper that they were looking for people or clinicians working or coming to work in the National Multiple Sclerosis Center in Belgium. And that was just the town next to where I live, or I lived at that time. So I took my bicycle and took a ride to the city, the town next door. And they told me, Kris, you are too young to do something here. You're only 14. And so I told them, but it's impossible that I cannot do anything here. And so they told me, yeah, you can work as a volunteer, but we cannot offer you a job, of course. We cannot pay you. You're too young. And I told them, I am not looking for money. I just want to do something. If I see all the people here in their wheelchairs, I must be able to do something for them. So the next day I took my bicycle, went back to the center, and I started to work there from my 14, and I spent all my holidays, school holidays, I was at the MS center, helping people, helping patients, riding with the wheelchairs from their rooms to the physiotherapy, and I knew everybody, and everybody knew me, and it was really fun, and I'm sure that had an enormous impact on my life. I even met my wife later on in the hospital, who was also working as a volunteer and is now a dermatologist. I learned at a very young age what care was all about. Not the clinical content, of course, but was taking care of people, and it had a huge impact on my work, and still has a huge impact on my work right now.
That's an inspiring background. I'm curious, as you went on from those teenage years, kind of what the subsequent steps in that path were for you.
Yeah. Well, then I was studying science and mathematics until I was 18, and so everybody thought that I would go into economics or engineering or medicine. And then I did my bachelor in nursing and my master in healthcare administration and policy. And then later on, I started to work at university. It was around 1999, the year 2000, when I started to work there as a research fellow. And then between 2003 and 2007, I did my PhD, and I obtained my PhD in public health, and then some additional studies on economics and operations management. And then importantly, I did a postdoc at the IHI in Boston. And then it all started. I became a professor at Leuven University. And now I'm combining some academic work, some work at our academic medical center within the team of quality managers. The academic medical center is the top 40 hospital on the Newsweek top hospitals worldwide. So it's an interesting, large academic medical center. So I know what quality of care is on a daily basis and how to collaborate with clinicians and with managers. And my third role, next to my academic role and my work at the hospital, I'm the chairman of the National Public Health Research Institute in Belgium. We have more than 1,000 researchers in our organization doing policy work for the Belgian government. So I'm combining research with a research team of about 15 highly talented researchers, PhDs and postdocs, and then part-time work at the hospital and some additional policy work as the chairman of the board of directors of the National Public Health Institute. So that's the combination.
That sounds like a really interesting mix that I would guess, in academia, maybe there aren't as many people who wear that many hats. To have the clinical role and the academic role and also the research chair role, is that common?
Well, it's common. We try to do it, and I have some other colleagues who also combine it. Certainly within the Faculty of Medicine, we have some real clinicians. I'm not doing clinical work. I'm doing managerial and supportive work within the management team. But joint appointments are something that we really try to work on also at the university. And that's a very interesting combination because I can do some research about adverse events, or my second victim work, or my work on quality management systems that I think we will talk about later on. But I also know what it is to implement it in an organization. And I know what the pitfalls are. I know the challenges. So sometimes with working only at academia, you become a kind of dinosaur and only in reading and thinking. But I know the challenges. I know the challenge of explaining the things that we write about at the academic, in our academic world and our academic outputs, but also to translate that later on today. I have a meeting with clinicians on second victim support. So it's combining the research, but also trying to understand what it means in practice. And that's a very interesting combination. The third role is a new role since 2 years, more a policy role on government level. A lot of politics involved, but I also learn a lot from my academic and my clinical world by understanding how politics works.
Wow, you must be a busy guy.
Well, it gives me positive energy, and as long as I don't learn to say no, that's my problem. But it's positive. It's positive. It's interesting. Certainly working with, like yesterday, I was teaching to 18-year-olds, first year of medicine, students in their first year of medicine. I was explaining them about joy in work and anti-burnout. And then today I was working for Brussels. And this evening I have a meeting with clinicians on second victim. So that combination is really it's a privilege to be able to do these different things.
Yeah, and with that broad overview, I think listeners will understand why it was challenging to whittle down a single focus for this episode, because there are a lot of things, as you mentioned, the second victim work and many other things in policy and government and research. So we'll do our best and go one bite at a time, as it were. But I'm curious, in that journey, what were the specific to healthcare quality? What were the quality thinkers that you think most shaped your thinking, and what did they help you to see more clearly?
That's an interesting question, because I'm a real fan of the old quality gurus, and then we always refer to Deming and to Duran, and then we talk about Feigenbaum, and then we talk about Donabedian. And that is really interesting stuff. Certainly the Deming and Duran's trilogy I'm using at a daily basis, also in our new quality management system, design, control, improvement. It's really so interesting if you talk and if you read about new models or new methods in quality management, you can always see the link with the old stuff. And so also at university, I teach about Deming, I teach about Duran. So that's really interesting. But one of my favorite quality gurus or people that that really helped me in my thinking is Philip Crosby. And Crosby was there in the 1980s. Interesting guy, but we mainly know Crosby from his zero defects theory. And zero defects, I know, and I agree with Deming and Duran that zero defect is impossible, because you always have system variation and the process is never under control. But what I really think that is really interesting about the zero defects theory of Philip Crosby is that can be your only aim. Your only aim can be zero falls in hospital. You cannot say, well, we will expect this year our goal is 5 falls, because that will be significantly better than last year. But you cannot say we expect 5. So the zero defects, there is only the zero defects. That is the aim. And that's interesting work that we are also now using with one of my PhD students when we have a PhD study of Alexander, one of my PhD students, who is looking at the cost of poor quality. We're always also using the Duran work, but also the Crosby work with the zero defects, and trying to understand that, while we hope that he's correct, that focusing on prevention, that the total cost will go down. So that's one of the old gurus that really helped me in my thinking about quality. But if I look at that people that inspire me right now, well, if I look at the work that Lucien Lieb did over the past years and decades, and the work that Don Berwick, or the messages that Don Berwick is providing us, or Maureen Bissognano, these are real people who are inspiring me on my daily work.
I wanted to pause for a moment to invite you into something I'm starting with this podcast. If something from this episode connected with your own experience, where you've seen it work or not work, I'd love to hear about it. There's a short link in the show notes where you can share what you're seeing in your own work. It takes about a minute. I read every response, and over time, I'll be sharing what we're learning together in future episodes and in other ways, and giving shout-outs during future episodes to people in the community who share ideas that really move the conversation forward. If you're up for it, I'd really value your perspective. Thanks. As you've mentioned, the focus of our discussion today is going to be on quality management systems, and this is a particular focus for you. I know that you've run a few workshops at this point at the International Forum for Quality and Safety in Healthcare, and perhaps in other venues. And this is, when you're presenting this is the Flanders Quality Management System, or FlaQuM. I don't know if that's how you pronounce the acronym. So I'm wondering if you can just get kind of level set for me, what FlaQuM is, how it came to be, so that our audience kind of understands where that started.
Yeah, it's been an interesting. It's been very interesting over the past years to develop that Flanders Quality Model, FlaQuM as we call it. And so the region where we work, we're in Belgium, and Belgium. Most of the international colleagues know Belgium because of the capital, Brussels. But Belgium is divided into a Flemish-speaking community and a French-speaking community. Brussels is in the middle. But in the Flemish-speaking, in the whole of the country, in the whole of Belgium, we have about 11 million inhabitants. And 6.5 million inhabitants live in the Flemish-speaking side of the country, where we have about more than 50 general hospitals. And a lot of these hospitals, or nearly all hospitals, were working on hospital accreditation. So they were really using accreditation standards. They were using the Dutch accreditation system that is linked to Accreditation Canada or Joint Commission International. But around 2019, 2020, there were hospitals who were saying, well, it had a positive impact, the accreditation, but we want to go to a next level of quality. We want to use the money that we have for real quality improvement, and our goal should be to bring quality from bedside to boardroom. And what we saw that happened in a lot of the organizations with accreditation, and I see a lot of positive effects of accreditation, was that it was a kind of top-down thing. The goal was to get the accreditation. The goal was not to improve quality. The goal was to get the label, to get a certification. And so hospitals contacted us and said, can we develop a kind of new model that will bring quality not only top down, but also bottom up, but also more stakeholder involvement of patients, of kin, and of providers? And can we try to build a kind of roadmap that can help us by keeping the positive things from the accreditation, but building on top of that a layer that will make quality sustainable, and not sustainable from a eco-friendly point of view, but really implemented? Because what we saw in a lot of our organizations, and I also hear it now from other countries, is that 1 month after the accreditation, the level went down. And 6 months before the next wave, we all started to work again on quality, or the focus was on quality. And so the goal was that momentum. And that momentum is positive. But I would like to find or that is my maybe naive goal or naive aim. I want to find a model or develop a model where it will be sustainable quality, where it's 24/7, 365. And I know that it is naive, but that's the challenge. And we are happy that we have a group of more than 20 hospitals in our region that are developing that model together with us. So FlaQuM is not developed by Leuven University. It is developed by Leuven University, who has the coordination role, but together with more than 20 general hospitals, academic medical centers, 2 rehabilitation centers, and 2 mental health institutes. And that combination, we learn a lot from each other. So it's a co-design model where we have 3 main parts in the model, where we say the first thing you have to do is to rethink your vision on quality. Because in the previous phase, the vision was, the goal is the accreditation. We do JCI, we do Accreditation Canada, we do Qualicore, we do Autorité de Santé. And now we are using our multidimensional quality vision model, what we call our house of trust, to make them really think about their priorities and what is quality all about. It's more than 6 dimensions of quality. So we developed some models for that. The first thing is quality vision. We call it think. The second is our do. That's quality co-creation. We developed within one of the PhDs developed by Fien Claessens. We developed a roadmap how to help organizations in making quality sustainable in a 6-driver diagram with 19 building blocks that is published, open access that hospitals can use. But we also developed some maturity matrix to measure the maturity. And maturity matrices were developed by Philip Crosby years ago. So we have learned from Philip Crosby. And in our roadmap is based on Durand's trilogy, including then additionally leadership and culture and the context. And so we have two phases, the think, the quality vision, with the House of Trust and our multidimensional model. We have the do, quality co-creation, make it happen. But then a third pillar of the FlaQuM model, next to think and do, is learn and innovation. And so we are convinced that you cannot make that happen on your own. You have to do that in what we call a consortium, a group of organizations who want to learn from each other. So these are the three pillars of our FlaQuM model: think, do, and learn. As easy as that, but very complex to make it happen.
Yeah. Simple, but not easy, I can imagine.
Not easy.
Yeah. So you're talking about the 6 pillars, and maybe you can just elaborate a little bit more on that for me. What I hear is the Durand trilogy, plus 3 more pillars around leadership, culture, and context you mentioned. What inspired the inclusion of those components?
Well, those components, there is nothing new in those components. If you read them, and if you read the +1 paper that Fien Claessens published as part of her PhD, there is nothing new in there. But what Fien did was a 2-step approach. She first looked at all the available models in literature. And that's why when we were presenting in Oslo, for example, a few weeks ago, our model, people were saying, well, there are some similarities with our model. Of course, because we used the best of all things and combined it into a new model. But then what Fien did was to redesign the knowledge from the evidence and of all the published models in published literature and gray literature. And she used more than 50 different models to make the first version. But then we redesigned it together with these hospitals. And so the model, the roadmap with the 6 drivers, where the first driver is quality design and planning, the second is quality control, then we have quality improvement, so design, control, improve, that's Durand. And then on top we said, okay, if you do the design, control, improve, then you can work on leadership. And if leadership is involved, then you will work on your overall quality culture. So that's the 5th driver, quality culture. And the 6th driver is a kind of umbrella driver, is quality context, internal context and external context. And the way that we translated all the evidence from the literature and all the models, like Scottish models and NHS and IHI and EFQM and everything, that was translated by quality managers from our participating hospitals. And so that is why we think that we now have a model that can work, because it was developed with and co-designed with people from general hospitals, academic medical centers, rehabilitation hospitals, and psychiatric hospitals. And so that was a very interesting approach that we used to develop the roadmap in Fien's PhD. And now we are redesigning it continuously because we have new ideas, there is new evidence, there are new findings. And right now there is interest from other countries to translate the model into other contexts. And so I think in a few years' time, we will have a 3.0 or a 4.0 model based on, well, the world is changing. So our models also have to change. But the co-design and the co-creation together with the organizations, that's the strength of the model. It was not something that was developed by a PhD student on a desk in an old university. No, it was developed and discussed together with organizations. organizations with 250 beds up to an organization with 3,000 beds. So that's the interesting thing. That's an interesting combination, I think.
Yeah, I'd like to tap just a little more into that because of, I hear you leaning into that. And the diversity of perspectives is certainly one of the themes that I'm hearing there, that you had these different hospital contexts, different managers, quality managers, a lot of different people contributing to that co-design. So diversity of perspectives maybe one of the advantages there. What for someone who's not maybe bought into that co-design, maybe it sounds like it's a lot of, a lot more work than just a top-down prescription. What are the other kind of tangible benefits in your mind? How has that been a force for good in this effort?
Well, the different perspectives are, of course, hugely important. Not only the difference between the general hospitals and the academic medical centers and the rehabilitation and the psychiatry. That was a huge advantage. But also a huge advantage were the people that were among our co-designers, our FlaQuM builders, we call them. And there were clinicians in there. There were psychologists. There were engineers. There were CEOs. There were nurses. There were medical doctors. There were physiotherapists. There were patients. And so the different perspectives, it has cost us a lot of work, a lot of time. It has cost us 2 to 3 years' time, but that's why it was a PhD. And all the different steps were published. You can read about it in the literature. If you look at the FlaQuM website, you can read the different steps that we took in that fabulous PhD of Fien. But although it was a huge lot of work and a lot of co-design work, also online, in Teams, in Zoom, but bringing people together. And that was the main advantage. And we see that is also one of the main advantages of using FlaQuM at the moment in organizations, where in our first quality design and planning driver, we have a building block on involvement of stakeholders. And I think that in previous years, a lot of quality management systems were developed by starting to measure indicators or starting to audit standards without first taking the time to think about our aim and our priorities and our goal. And what I see right now is that co-design work that we are also using within the organizations to make FlaQuM happen in an organization, it takes time, but it is something that also clinicians really like to do. Because what they hate about quality is that the chief quality officer will tell them, this is what you will do. And certainly with medical doctors, they hated accreditation because they were told what to do. But if you ask a medical doctor, where are the most unsafe acts or risks in your organization, they can tell you. So we will start with these type of co-design work, but what we have available right now are the models and the roadmaps and the methods and the surveys and the algorithms and the feedback report, because we produced all these different things. And that is also the work that we are now trying to translate into other countries, like British Columbia in Canada and in the Netherlands and in Australia. And I think they will win about 2 to 3 years, because they will not have to do all the work again that we did, but they can immediately start with the translation in their context. And so they will win a lot of time and a lot of money if they start with what we learned already, but they will have to translate it. You cannot just implement FlaQuM you will have to translate, and it will take you 2 to 3 years. But the first work that we did in the beginning of bringing all the evidence together, all the things, that is already done. And so that is what we are now. We think it will save other ecosystems a lot of time, and money if they do not have to start from nowhere and nothing.
Yeah, and I've had a few guests on here from British Columbia that I imagine are among your collaborators. You mentioned offline. You mentioned Ali Munyak's episode, and
this is kindness, I call her.
She's one of actually our most listened to episode, and she's great. We had and a few others, Kurt Smetcher and Lawrence Yang and Gail Grout and some others. It's been great. So I'm glad you're able to collaborate with them. And I'm curious, I do want to talk about the spread beyond borders, and that was a focus, it sounds like, with a variety of your collaborators in Canada, as you mentioned, Australia, Norway. But I'm curious first about the spread or the adoption kind of within this 20, I guess you said 20 hospital system. What do you know about the, kind of the spread, the culture change, the adoption? And if you're able to comment, also any differences in kind of clinical care, clinical outcomes that we're aware of? What are the kind of the downstream effects of all this great work that you guys have been doing?
Yeah. So I really look forward to collaborate with, for example, British Columbia, and it's Christina Krause, the CEO, who will take the lead in that. And I've been collaborating with Christina for years, and we really trust each other, and we will collaborate and we will rethink the models. And Christina is a great leader. Also, the group in the Netherlands. With Relinde, it will be huge fun and a good collaboration. Also down under with Australia, it's the University of Tasmania and Peter Van Dam, who is taking the lead there. There will be a PhD starting very soon in Tasmania on FlaQuM. So this is really great to understand the difference in context. And I think that our overall goal in 5 years' time should be to have not a FlaQuM, but a uniQuM, a united quality model that we can learn from. That is my very naive goal, a naive dream. But we have to do it with people who trust each other, who want to collaborate and who can collaborate. And we learn the same thing within the country or within the region. So at this moment, we have FlaQuM implemented in 23 organizations in our own region. So that's really good. But we also see the differences between the organizations. And in some organizations, it's really a strategy where the CEO is totally aware. In some of the organizations, it's more a project. So it's not a good news show. FlaQuM in the 23 organizations, well, there's still a lot of room for improvement of the model, but also of the implementation. And what I learned there is what I learned over the past 30 years in healthcare. It depends on people. It depends on people who really want to take the lead. So the leadership driver in our roadmap, I think that is really an important one. And in our roadmap, with our 19 building blocks and 6 drivers, we talk about leadership. We talk about leadership on 3 levels: on personal and clinical leadership, on visible, supportive management and staff member leadership, and on executive and governance support, the 3 levels. And we will need all 3 levels. And there I see differences within our own ecosystem. And there will also be a difference between, if we look at BC in Canada, well, it's incredible for us. It's 2,000 kilometers wide. Yeah, it's Vancouver with a flagship hospital, but then up north or in the middle of the province, you have very small hospitals. And when I was in Canada, I learned about a hospital with 10 beds and with 1 nurse. There, the clinical leadership will be hugely important. But what I hope, or what we see in our region, is that having the models and the components and the basic components ready in visual models, into PowerPoint presentations, into validated surveys that you can use, that is a huge privilege and a positive thing, that you don't have to start from scratch and say, how will we do that? So learning from, and then bringing those people together. If I look at one of the strengths of our FlaQuM consortium, and it's a small region, Belgium, the Flanders because we're now translating it into the French-speaking community also. About 20 hospitals who will start to use it and are involved in a PhD of Mathieu Louiset, a very good friend and a PhD of mine, PhD student. Mathieu is translating into the French-speaking community, other context. But one of the main things that is happening in our region, in the Flemish, is that we bring those, what we call our FlaQuM coordinators, we bring them together every month, 1 month virtually, a Teams meeting where they change IDs and we send some new information. And the second month, we see each other a full day at Leuven University, and they all come to the university and they share their experience. And then somebody is saying, well, I had a problem with the implementation of that part. And then 22 others, oh, we too. Oh, I had a solution. Oh, I solved it like that. And so with the 3 pillars of FlaQuM, the think, do, and the learn, that's the third one, the learn, that is of major importance. And that we will have also to learn from, for example, Tasmania or from BC with real rural health and flagship hospitals, how we can also develop the learning pillar in FlaQuM. And that you can only do if you have real quality leaders like Christina and Ali and people there that know and understand the context. So it will be, I'm sure it will be an interesting journey, but a challenge.
So as you have, discussed more and more with the leaders you mentioned from around the world, how has your thinking evolved around quality management systems? What components feel maybe universal or essential, and which components or ideas maybe are more context specific?
I always have a lot of discussions, but positive discussions about that with the chairman of our international advisory board. In FlaQuM, we have an international advisory board with a bunch of highly respected people and experts. And the chairman of our international advisory board is Peter Lackman, the former CEO of ISQA, pediatrician and a good friend. He's my mentor. And Peter always tells me, well, there are a lot of differences worldwide, but there are more things that are in common, also on quality thinking. So together with Peter Lackman and with Paul Betelden, we developed a multidimensional model in our House of Trust that was created in the brain of Peter and Paul, and I had the privilege to collaborate with them. But also in our roadmap thinking, in our second pillar, in our do, so the think, do, learn, in the do, in the roadmap, Peter always tells me it starts with planning. The basic ideas are also in the planning, combining the stakeholders who are patients, the next of kin, the families, the relatives, but also the providers. And we need to, I think that is a universal thing. That's global. The planning, the control, and the improvement, that's global. I think the leadership should also be the same, but leadership is highly related to culture. It will be different in Flanders. Well, it is different in Flanders and in Wallonia, the French-speaking side of our country. There is a difference. So how leaders will take the lead will be culture dependent. If we would, let's imagine that we can introduce FlaQuM not only in Tasmania and in BC and in the Netherlands and in Belgium, but for example, I was last year in Singapore. That's a total other organization, total other context, also another culture. What if we would implement FlaQuM thinking in India or in Arab countries or in Africa? So I think that in our thinking, in our quality vision, worldwide on global level, quality is multidimensional. It's about hard indicators like safety and effectiveness and efficiency, but it's also about dignity, respect, kindness, empathy, compassion, partnership. So it's front office and back office, as I explain it in our House of Trust. It's about front office and back office everywhere, worldwide. But the culture and the context, for example, the legal structure of your organization, if you have a very good or well-developed inspection system in your country, it will be different than if you don't have an inspection. Maybe in some countries you really need accreditation, and in others, maybe not. So that will be different. And that is the reason why we will not implement or develop FlaQuM in other contexts without what we call a regional hub, like Healthcare BC, because they know the context, they know the structure, they know the people, and they know the challenges. We will not do it from Leuven University in Tasmania. Impossible. But we don't know the... So I think that the Duran trilogy, the first three drivers of our driver diagram, design, control, improve, these are global. But the three on top, the leadership, culture, and context driver, those three are local. And it will be the combination of both that will make it happen. Because if it would only be the three basic drivers, design, control, improve, and we have been working on that for 50 years, for 60 years, for 70 years, because these were developed by Duran in the 1950s. That's 67 years ago. Then it would all be solved. But we still see variation that is unwarranted. And I think that the unwarranted variation has got more to do with leadership, with culture, and with context than with design, control, and improvement. But I cannot prove it. That's what I'm discussing with my mentors and with my coaches and with my colleagues on international level. And these are the type of discussions that we have in our international advisory board.
It sounds like in the same way that you described the learn part of it and the getting together once a month and the managers talking together, or not the managers, what was the term you used for the...
We call them, or they call themselves, so we call the meeting, the FCI, the FlaQuM coordinator intervision, and they call themselves right now, I'm an FCI. So that was their choice. But it was in co-design, so they created it, and so we call them our FCIs, our FlaQuM coordinators who go into intervision. Gotcha. We call them our FCIs. It's a great group of people who are really the strength behind all the models.
And so it sounds like in the same way that these FCIs, so the FlaQuM coordinators, get together, share learning, and try to kind of grow together. You are kind of the beneficiaries of similar learning and sharing when you're working with local organizations. You mentioned Health Quality BC as one, and then also the people in Tasmania, that there's probably a shared learning and your own models might be influenced or evolve as a result of kind of kicking the tires on that when you do change the leadership culture and context.
Well, that's what we hope. Well, our university is a very good university, and I have a great team. But we also know that we have to learn from other people, and that's the huge privilege that we have in these times, that we can Zoom and collaborate and Teams with people worldwide. Okay, we have to look at time difference. My meetings with Christina Kraus is late afternoon for me, early morning for her. But that works. So we have to learn from each other. We have to bring people together. And also in our international advisory board, we have people from around the world in our internet, and we can learn from each other. And that's what Peter Lattman is always saying. There are more things in common than that are different. And we have to also, from a safety 2-point perspective, learn from the good things that we can learn from each other, and not only think at the differences. But I hope that in 4 to 5 years' time, our models and our methods and our surveys will be 2.0, 3.0, 4.0, next level, based on what the international community learned us.
What do you think, looking forward, what do you think this work looks like in 5 years, if it's evolved to the 4.0, 5.0 version. What is happening in the world when that is when that newer, more refined version is unleashed and unleashed more broadly?
What I really hope is that we will understand variation. I had a discussion this morning with one of my PhD students, Matthias, and his PhD is about understanding variation in healthcare quality, and quality from a quality management system point of view, a teamwork point of view, and an outcomes point of view. If I look at one of the previous PhDs that we did with Astrid van Wilder, and we looked at really on patient level hospital minimal data, and we looked at variation in mortality, we see that the variation in mortality in our country is not depending on the region, it's not depending on the number of beds, it's not depending on teaching hospital or no teaching hospital. So it must be something more, well, I always say, I think that the variation exists because of a kind of invisible engine in an organization. There is an invisible engine. What I hope is that we will step by step try or learn to understand that invisible engine. And what I hope is that FlaQuM, or the quality management system that we are building, the UniQuM for the future, that will describe the invisible engine. And once we understand the invisible engine, then we can change the engine. Then we can put some more oil or more, I don't know what. We can change it, but we will only be able to change it if we understand it first. And so what I see right now is that what we thought 10 years ago, if we build in structures and we build in quality standards like accreditation, which has a positive impact, then it all will be solved, and we will go from structures directly to the outcomes. But what we see right now is that even in a region where all the hospitals have the same structures, or nearly the same structures, that there is a huge unwarranted variation in outcomes. So I think that we have to go to Donna Bedian again and to say there is no direct relation between structures and outcomes. There is the process in between. And that process is what I call, or what we call, the invisible engine. Something is happening in that organization. And so what our idea is that you have to think about that invisible engine. You have to make it happen, and you have to learn about it. And so what our goal is to understand that engine, and that engine we call FlaQuM at the moment. That is our think, do, learn, is trying to understand what is really happening on organization level, on hospital level, for example. But also we are measuring at the moment within our organizations psychological safety on team level, because also that will be part of the invisible engine. And if I look in 5 to 10 years' time, my hope is that before I retire, I have another 15 years to work at least, that we understand the invisible engine, or understand it better. Maybe that's also naive, but that's the goal of people working at academia, I think, to be a bit naive and to keep on searching. We will not be able to search or find the solutions if we do it alone. We have to do it on an international level with people who are critical friends and have an open psychological safety that you can ask the critical and the critical questions and the stupid questions, because that's the only way to understand the variation. I would not accept the variation as patient, so we have to learn from it. The invisible engine, understanding the invisible engine, that's the goal.
What do you think is important for leaders? What mindset shift is important for leaders who might be the future adoptees of this model?
It's an interesting one, and it was a surprising one for us. We totally underestimated the change that leaders had to make. not the change in signing a contract and saying we will now collaborate with you, but in, as I call it, in their mainframe. Because we have been trained to think that structures lead to outcomes. And we were trained, if we follow the protocol, care will be okay. We were trained like that as medical doctors, as nurses, as physiotherapists, also as managers. If you do what is in the evidence, then it will, but it's not enough to do it. We have to continuously improve it. And what I have seen over the past years, and I also see the discussion right now in other countries, if we talk about quality management systems, is that if we want to go 2 steps in the positive direction, we need to do a step back first and to really think why we are doing that. And so what I saw in and what I feel in the discussions that we have with CEOs and with chief medical officers of and chief nursing officers and chief quality managers of organizations is that it's very difficult for them to explain what their goals are, what their vision is. Yes, we want to do quality, but what do you mean? And so I underestimated the effort for the mind shift, because we were trained as protocols, procedures, doing it, and then accreditation, certification, going to a course. No, it's daily work, it's hard work. Also for a CEO to understand the complexity of the work of a quality manager. I see a lot of CEOs and chief medical officers who have no idea about the complexity of the work of the quality team. If leaders want to adopt or adjust the work that we have been doing or translate it into their own organization, the first thing is that they have to be convinced or accept that also they will have to change their vision about quality. That's our first pillar to think. I think that is one of the most important things to have the leaders and also for quality managers. It's not easy to make the mind shift. We underestimated that, but the models that we produced and the surveys and the measurement instruments are helping these people to objectivate it and to measure it and to receive feedback and benchmark reports. For example, benchmark reports on psychological safety, benchmark reports on quality vision, benchmark reports on your maturity level of your quality management system. But it means being open to some types of feedback that is something else than number of beds, profit, patient satisfaction. I see that as one of the main challenges, Jason.
Yeah, well said. And as I've come to experience with all of these conversations, we open so many more doors, so many more hallways that I want to walk down in the conversation than we have time to do. I do wonder, as you look forward in this work, what gives you the most optimism?
Oh, the most optimism is if I was teaching yesterday to my class of the first years of medical school at Leuven University, where I see 500 highly talented young people, 18-year-olds, like my daughter, friends of my daughter in my auditorium. Then they are sending pictures of me presenting to my daughter. But if I see them and I explain them some things about what care is all about, the first time I talked to those young, highly talented people, I told them about my own patient story with I had a pancreatitis. And so they didn't understand what it was because they didn't have a clue about it. But I explained them what I felt and what I noticed. And when I see them and when I see the eager of learning and I see the positive, that makes me very positive. But it did also make me positive if we have the opportunity to have the time to explain about quality management systems to highly experienced CEOs and CMOs and worldwide, that they say, oh, this is interesting. This is something I have to do. So seeing people that are motivated by our work and inspired by our work, but I also see in the young people, but also in the, not the old, but the experienced people, that they are all willing to make care better. If you talk about quality with a medical doctor, he will say, well, it's about procedures. But if you ask them, hey, how can you improve your care, or what would you improve if you had all the possible, they can, then you see them, then they receive, it gives them joy in work. And so that makes me positive, that I see a new generation that is ready for that, but that I also see the experienced generation that they understand we really have to do some work about it. But it will take time, and it will be working on the think, on the do, and on the learning from each other on international level.
Perfect place to round out our conversation today, Kris. I'm so grateful for you and your work and your time today. For listeners who'd like to follow your work or connect, what's the best place for them to do that?
Well, LinkedIn, my LinkedIn page, I try to update it quite frequently, and also my krisvanhaecht.be website. But I think that LinkedIn is the best place to learn from each other. It's a great community, and that works. So it would be nice to see some new friends on LinkedIn.
Very good. So we'll link to the resources as well as the things that we mentioned in the conversation today. Thanks so much. This was a rich conversation. I really appreciate you going through all of the incredible work you've done with FlaQuM. I know we only scratched the surface and also didn't get to dive into many other areas that you've worked on, but so grateful for the conversation today, and thanks for sharing everything that you do.
Thank you, Jason. Thank you.
Thanks so much for listening to today's episode of Leading Quality. If you enjoyed the show, please take a moment to like, subscribe, and share it with someone who might find it useful. You can find all our episodes at leadingquality.buzzsprout.com or in your favorite podcast app. The show was written and hosted by me, Jason Meadows, edited by Milan Milosavljevic, and produced by Thrive Healthcare Improvement. See you next time.